Care planning is a term typically used by the nursing departments. However, it is a very important aspect of how we can plan the care for our patients. Let's take a closer look at care planning step by step. As you can see, we have a system where we're going to look at assessment, making a plan, having interventions, and then evaluating how the plan is working. Or you can remember it as API. Assessment is the first step, and this is where symptoms are identified and other pertinent information about the individual patient. So it is a really important step. And we want to assess our patients each and every time we visit them. The first time you may visit a patient that you know that you'll be visiting a number of times, whether you're long-term care or in hospice, that first assessment is going to be more comprehensive, but each subsequent visit will be important to assess to see if there are changes. So you'll want to do that spiritual assessment and touch base with your patients. The spiritual assessments are a number of different formats and models that you can use. Use the one that's recommended by your facility, or if you're a solo chaplain in a facility, take a look at the different literature, take a look at the literature to see which model suits you best and will serve your patients or residents best. So taking a look too at the physical condition, it's important to understand the physical condition of our patients. Even though you may be dealing with the patient spiritually, and so looking at them from their emotions, how they feel, what they have to say, they also are impacted by their physical condition. For instance, someone who has recently had a diagnosis of a life-limiting condition may have tremendous feelings of guilt, of anticipatory grief, shock, disbelief, maybe even, how could God do this to me? So you can see that that would be a very important one. But other symptoms, physical symptoms, are important as well. A patient with respiratory distress, for instance, that visit might be better spent for you reading scripture to the patient, singing hymns to them, connecting them with their past, other things that they don't have to have the effort of speaking. When you're short of breath, you can get very cranky and irritable, and especially irritable if you feel you have to answer the same questions over and over. You feel like you only have a certain number of breaths. You need to eat, you need to be able to sleep, maybe transfer to the chair. And all of those things take effort and parts of the amounts of energy that you have where you may not have much left. So be sure that you take those kinds of things into consideration with your assessment. Psychosocial factors include the patient's culture, their education level, their family dynamics. They're part of a shared worldview with their family and their community. It includes their religion, of course. But the more we can learn about their world, the more effective our care will be and the more personalized it will be. So as we take a look at creating a plan, it will revolve around the goal. And the goals of care are developed with the patient and their family, in addition to the healthcare team. The goal should be SMART. It should be specific, measurable, achievable, and timed. So reflect on the patient's priorities as you design a plan for them, and help move the current situation toward that desired outcome. Honing in on a goal that's SMART, then we can develop interventions that will be effective for the patient. Interventions are specific actions, so really be taking a look at making sure that your interventions are action items, that you will pray with the patient, will identify specific scripture that is comforting to the patient. You will make a consultation with the community pastor. Those types of things are specific actions. Things like, for instance, let's just take a silly example. Let's say that my assessment is, my goal is I want to lose weight and get in shape. So maybe every single New Year's, I have that same goal. And one of my interventions were buying an exercise bike and a diet book. Well, are those action items, or are they tools and supplies that I might be able to utilize as interventions? So far better would be an intervention of, I'm going to get on my exercise bike and ride it for 15 minutes every day. I'm going to buy a diet book and I'm going to follow the plan for the next 2 weeks. Then I'll weigh myself, our evaluation, and see, did the plan work? Do I see a difference? Am I moving toward my goal? So when I do an evaluation with a patient for their spiritual life, we'll be looking at comments that perhaps are, for clinical folks, may seem a little bit more nebulous than, for instance, losing 5 pounds, but will be how the interventions are affecting the patient. Do they feel more relaxed? Are they more at ease? Do they state that they feel more connected to their family, to their community? I had a patient early on in my career as a hospice chaplain who felt that he couldn't connect with God because he couldn't be in church. However, on doing a life review, talking more about what mattered to him, we discovered that he had felt very close to God when he would be on a vacation or trip with his wife, his late wife, and they would talk about scripture. She would read the Bible, they would talk about it, and he felt very connected to God during that time. So we related that to the idea of having, for instance, having a member of his faith community coming in to read scripture with him and talk with him about it. There was actually a volunteer in our hospice program who was very much in alignment with his faith tradition, and she was able to visit a little more often, to have a friendly visit that included scripture readings and talking about that too with him. When I came back a couple of weeks later, he stated that he definitely felt more connected to God and really appreciated those visits that helped him understand that God was everywhere and that he could feel connected even though he wasn't sitting in a church pew. So directly observing and reporting that information with the patient and family, and identifying that individualizing your plan can make a big difference for your patient. I'm going to guess that you're already doing those things. However, the important part then is to be sure that you're writing those things down in that kind of clear and concise method that gives anyone looking at your chart, whether it's another chaplain who's going to be covering for you for vacation, another team member, or perhaps even a surveyor or reviewer, that they can see the added value that you've contributed to that patient's care, and continue that care so that it's seamless on the part of the patient. So let's take a look too at how we can conduct our visits and how it can work to help us in developing this type of plan of care. Now, it's often that we can complete our checklist where we feel like we're finished with the required part of the visit, and good, now fun time to be able to sit and chat with our patient. And now, obviously, this is going to depend on the different circumstances that you find yourself in. Obviously, if you've been called to the emergency room and you work in the hospital for someone in distress, that's a very different scenario than if you work in a long-term care facility and you're visiting on a routine and regular basis. But however, I think it applies to most all of the interactions that we have with our patients. So I kind of jokingly call it the tea and cookie portion of our visit, that we have time to chat. We're going to be talking about different aspects of what matters to the patient. And one of the things that I think is so important is to think of whether the interaction is maybe sometimes charted as a social visit. Is that really therapeutic? And each interaction that we have with our patients should be therapeutic. We should be listening for cues to help us understand more about the patient as a person. So the chat can reveal those aspects that can be extremely important for us. For instance, let's say that you are a chaplain in a facility where you're going to be visiting a patient on a regular basis. And the patient is able to communicate with you, and they're able to tell you a lot of different things. what a wonderful opportunity to find out what kind of things do they like most. Have a list of their favorite scriptures, of their favorite hymns, those types of things, because eventually you will find that the patient is going to become more and more unresponsive. They may be on hospice, or perhaps you work in hospice, and they get to the point where they can't answer those questions any longer. But you already have a little, information in your toolkit to be able to know that how you will be able to provide comfort for the patient even when they're unresponsive. So let's look at some of the questions that we can ask. What did you do for a living? What are your hobbies and social activities? What was your favorite book, song, movie, your favorite scripture, your favorite hymns? What was it like growing up? What hardships have you overcome in your life? What was your relationship with your family like? So other types of questions that are included here are the care issues that might be troubling the patient. Are they able to attend to their activities of daily living? They may feel a little bit sheepish about answering that they're not able to brush their own teeth with you, but that helps to point to the kinds of worries that they may have about being a burden for other people. And yet, many of these activities of daily living, brushing their hair, brushing their teeth, feeding themselves, being able to toilet themselves, all of those kinds of things are crucial for keeping our health, keeping our ability to function as human beings and be alive. So again, they may not be wanting to be a burden on anyone. They may not be able to think clearly. They're anxious or depressed. And that really creates a vicious cycle. When you are anxious or feel depressed, you worry about that more, which then creates more anxiety and more depression. So we want to be able to identify how they're feeling about that. Not feeling worthwhile or valued. Perhaps they feel that the care team is not treating them with dignity or respect. So that would be an important one to be able to report to your team, to talk with the team manager about, or the director of nurses, to look for ways that the patient could be treated with more dignity and respect. Perhaps some of the healthcare professionals in your facility have fallen into some bad habits. Maybe they turn on the television to, Jerry Springer, and the patient is very annoyed by that. Maybe they're not draping the patient properly so that they feel exposed. Maybe they're chatting with each other instead of talking with the patient as they provide the care. So not having control can be a very large burden for the patient, because even though they don't want to be a burden to others, they want to be in control of what's going on in their life. And that may have been part of the role that they have in their own family. They're the ones in control. They're the ones who kind of run the show, direct the traffic of the family, and determine what's going to happen or not happen. So when we discover the patient feels out of control, that can cause a lot of distress, anxiety, even agitation and aggressive behavior. So if they don't feel supported or listened to by their caregivers or the staff, that can be a real burden for them as well, and create a lot of anxiety. And it's something that we want to release and ease the burden of suffering that they experience because of that. So when we take a look at what are those symptoms that we can take a look at that relate to our spiritual care for the patient, this is just a sample listing. There can be many more. But loneliness. Research has shown that loneliness is a huge impact on our mental health and our physical well-being as well. And it's something that becomes more and more common. During the COVID pandemic, many people suffered with loneliness, even to the point of having severe mental health issues, even potential suicide risk. Any patient in a nursing home or a hospice or even a hospital facility, an older person may feel very lonely, because they've lost many of their companions and friends. So what are some of the goals that might be involved here? So one thing might be to reduce the sense of loneliness and maximize the sense of connection with others, to integrate their new role into their identity. Reconciliation is an important one, and that reconciliation may be indeed with the family and friends, with their church community, with God. They may have felt alienated from their congregation. Perhaps the congregation didn't really have a good plan in place for their parishioners who are sick and ill or disabled. And they may have withdrawn from helping the patient or working with that person because they felt uncomfortable. They didn't know what to say. Perhaps the person lost a loved one and then drifted away from attending church. So helping, or even with family dynamics. Perhaps I had a patient early on when I worked as a hospice nurse. I couldn't get the patient pain under control, and I just was struggling with figuring out what medication should I use. But a wonderful mentor of mine helped me understand that the patient may have spiritual or social, cultural, different types of distress, as we saw earlier in the lesson about the model of suffering. So social, emotional, spiritual, as well as physical pain can cause suffering. And it turned out that he had a brother who he really wanted to reconcile with. They hadn't talked for years. They had had a bad argument. They claimed, I don't even remember what it was about. Now, once we worked on reconciliation with the patient and his brother, they remembered every detail, right? Don't we always? But by helping them and working with them for maximizing their feelings of connection with others, with maximizing their self-forgiveness, because what would have happened if the brother had died and the patient was there wishing for reconciliation? Helping that patient to forgive themselves. All those types of things can really be important for the patient in that regard, and to maximize their reconciliation with God or the higher power of their faith tradition. And again, we're looking at working with them with their faith tradition and companioning them on their personal journey. A feeling of powerlessness, very, very common with folks that are ill, and very difficult because when you're in the hospital, you're used to having things your way. You want to have breakfast at a certain time. You have the way you like to prepare your coffee. You like to have your bedtime at a certain time. You want a quiet time to contemplate or meditate or read the Bible. So all of those types of things are taken away from us when we enter the hospital or a nursing home. And when there are times that it's by design and needed and necessary. However, it doesn't mean that we don't feel powerless at the same time. So helping to maximize autonomy or a sense of control, reducing the level of fear associated with death and dying, if that's the situation with the patient, or long-term illness, their fear of disability, maximize their sense of meaning and purpose. Coping skills is another very important one, where if the patient has an issue with a lack of coping skills, their coping skills are ineffective, to take a look at how their goal might be to increase their ability to cope and have resilience. Increase, again, the sense of control, which enhances their ability to cope. The patient can recall past times they were able to cope with a difficult situation. And despair. If they're feeling that sense of despair that it's all for nothing, there's no point, there's no hope, to help them with their clarification of their values may be part of in the goal list. That the patient can honestly express feelings toward God and family, because sometimes that despair can be because we don't feel we can be honest in sharing our feelings. We don't have anyone that will listen to our feelings, that will accept those feelings. Perhaps they've tried to talk with their own pastor and said, I'm so angry with God. Why did God do this to me? Well, the pastor may not be trained in clinical pastoral education or have a good grasp of how to do pastoral counseling, and may fall back to that feeling almost of defensiveness as a representative of God. That pastor may feel the need to say, oh no, don't be angry with God. God is there for you. kind of God won't like it, which obviously that those of us who've worked in the field of healthcare chaplaincy, especially hospice chaplaincy, will know that truthfully, God has broad shoulders, that if we're angry with God, we're still in connection with God. And that connection is something that then we can work with, and that we can be the ones that the patient can tell their honest and true feelings with, and that we won't judge them, that we're there to listen, we're there to companion them, even if it means going into what's often called the dark night of the soul. And I think that's a really important part of being able to companion them, and yet keeping in mind that we do want that goal for them to feel like they can come out on the other side and be enriched. So another goal might be that they feel supported in their sources of hope. All right, so let's take a look at interventions that are possible. So again, we want specific activities and actions that we can take for any of these types of symptoms that will help us toward the goal that we and the patient have come up with. So with loneliness, to explore the frequency and quality of social contacts. Quality is more important than quantity, and it may be that there are some ways that we can help bring in other people that the patient can connect with to feel that that loneliness is not an issue or a problem anymore. We want to listen with empathy, have restatement, validation, clarification, even using silence. If a volunteer is available, that would be a wonderful way to help combat loneliness as well. Some facilities even have paw pals or pet therapy visits, music therapy, art therapy, many different things that professionals who can come in or volunteers who can come in and share their expertise and find an outlet for for those feelings of loneliness and find a way for connection. So with powerlessness, identifying the ways that patients can have autonomy and a sense of control. You might talk with the other members of the healthcare team to see if there are ways that the patient can participate in their care and do some things on their own and help them to be sure that they are engaging the patient and involving them in their choices. Something as simple as I really prefer butter on my roll rather than margarine. It seems like a small thing. Is that really important? Well, if that's that one sense of control and it makes me feel better, let's do that. Let's do that for the patient. Encouraging participation is so crucial, and exploring their priorities. Sometimes as healthcare professionals, we have priorities that we feel the patient should participate in. They should do certain things. And sometimes healthcare professionals will even feel kind of some moral distress because they want the patient to be doing XYZ, but the patient doesn't want to. That's not part of their priorities. They don't feel that those things are important or valid or part of what they want in their world. So we have to remember that we have to let that go, that it's the patient's life, it's their choice. But I do believe that when we can be accepting of them, accepting of their choices, they're going to develop more and increased trust in us, and indeed may begin following some of the advice that we have and discover that we weren't trying to hurt them, we're trying to help them. And it may work, or it may not. They may prefer staying with their own priorities, and that's their choice, and that they can take a look at how that impacts their world and their life. So with coping skills, an important thing is asking what matters to the patient and having those discussions. Reminiscence therapy and life review can be very important here by helping them realize that they've gone through a lot. There are many things in their lives that they've been able to cope with, and simply allowing them to remember and recall how they were able to cope with different issues and problems, and yet they may have given themselves short shrift. Maybe they didn't realize that they had participated in that coping and had done a good job. Or maybe they recall, I didn't do such a great job, but I wish I had done something differently. So by saying, well, let's see if that applies in this case. And hopefully then that will begin to work in their favor. So exploring those past successful strategies is something that really helps. If a patient feels distressed and despair, to help them again qualify values, I think that that's a really important piece for them to have those discussions. To allow their expressions of uncomfortable feelings toward God or for their family or for the healthcare staff, whatever the case might be. And support sources of hope, to look for things that perhaps they can look forward to in the future, even if the participation might actually have to be modified. So how do we then evaluate? We need to come back and think about the evaluation for each of these types of interventions that we've already dealt with the patient. So we want to say that the patient will, for instance, the patient may have reached out to family for more connection. They've seemed more relaxed after validating their feelings. They agreed to a volunteer visit once a week. That would be an evaluation of how that worked toward the goal. Reconciliation. The patient had felt he couldn't be close to God, but he accepted prayer and seemed more relaxed and at peace. Powerlessness. The patient states that he wants a shower in the morning instead of the evening, and the staff was able to accommodate that. Terrific evaluation and successful to meet that goal. That the patient will discuss with the team physician her priorities for her pain medication. Coping skills. The patient talked about past conflicts and states that she's ready to let them go. A patient enjoyed reminiscence and life review and stated, "I guess I'm tougher than I realized." Despair. The patient completed an ethical will to communicate their values to their family, or the patient discussed future plans with the family to assure that they will be okay. And that's a very important part of when a patient does feel despair, especially if they have a life-limiting disease or you're on hospice and the patient is trying to prepare and they may be resisting because after all, they feel like they can't die until their family is taken care of. Well, by helping to talk about those future goals and plans can really help the patient to understand that the family will be okay. They're going to have grief because the patient has died, but they will be able to go on and move on into the future. But helping them participate in that, creating a plan, creating those types of things that they can talk with their family about and connect with them about, they'll be assured that things will be okay and that they can relax and be able to be part of that process.